The next session will be on the medical debates. The session will be chaired by Dr. Shoiban Mukhopadhyay, Dr. Spandan Bhaduri, Dr. B.P. Pandey, Dr. Sujato Chakraborty, Dr. Minal Kanti Das, and Dr. Amal Khan. The moderator for the session will be Dr. B.K. Bhal, and the expert panelists will be Dr. Pralay Chakraborty, Dr. Devargo Guha, Dr. Devdatta Majumdar, and Dr. Suman Chatterjee.
Who is moderator will be P.S. Banerjee, sir.
Oh, okay, sir. Then the moderator will be Dr. P.S. Banerjee, sir. So I request the chairperson and the moderator to please start the proceedings.
Parthoda, you start.
Yes. So thank you everybody to attend this session. So this is a very really challenging situation, heart failure management in the renal compromised patient. As you all know, we frequently encounter. Go to the next slide, Raghu. So we all know that when patient comes with the acute or chronic heart failure, often they come with the associated renal dysfunction to some extent. Now, heart failure continues to be a national epidemic with the increasing prevalence affecting almost 2.5% of the adult population, an incidence that has not declined over the past 2 decades. Kidney disease, a chronic, also a national epidemic with increasing prevalence, affecting almost 16.8% of the adult population, an incidence that continued to rise over the past 2 decades. Next. Now, what is the relationship and what is the situation? Now, in CKD in heart failure, 50 to 66% of the heart failure patients present with the eGFR less than 60 ml per minute, 20 to 40% of the hospitalized patients with acute decompensated heart failure observed a rise in the serum creatinine in more than 0.3 milligram percent, and 20 to 30% incidence of ACEI has been noted in patients who are under the treatment of the heart failure. Similarly, incidence of, please, continue the previous slide, Raghu. Incidence of the de novo heart failure is known in CKD patients is around 17 to 21%. Now, 44% of the patients with end-stage renal disease also do have the heart failure. Next slide. Now, there is a clear cardiorenal connector mediator crosstalk between the heart and the kidney, causing the concomitant organ damage. That means when the heart failure sets in, there is hormonal changes, that is increase in the sympathetic nerve activity, RAS activity, aldosterone activity, so fluid accumulation, low perfusion, resulting in low organ perfusion, which also affects the kidney. Similarly, when there is a renal failure, there is again development of the hypertension, fluid load, anemia, and that also in turn affects the myocardial function. So this crosstalk between the two organs results in simultaneous deterioration of the organ dysfunction. Next slide, please. Now, cardiac and the renal diseases are extremely common and frequently they coexist. The coexistence of heart failure and the renal dysfunction is a marker of the poor prognosis. Now, what's baseline renal function is a powerful independent risk factor for the adverse outcome in patient with the heart failure. Go to the next slide. Now, this graph shows that prevalence of heart failure increases with greater severity of the CKD. So as the CKD increases, the incidence of the heart failure also increases. Similarly, on the right panel, it shows that the presence of heart failure reduces the probability of the survival to a great extent when the patient has got underlying CKD. So thereby they are two working simultaneously together, and unless you keep a balance of correcting the dysfunction, there will be progression of the end-stage disease. Next. Now, an undaunted barrier in the heart failure therapy is that the cause of worsening renal function during a decompensated episode needs careful thought, particularly regarding the volume status of the patient and whether the RAS inhibitor are of prognostic benefit. Because we all know the RAS inhibitor is a cornerstone of the guideline-directed therapy in heart failure with reduced ejection fraction. So thereby, when you use it, you have to take care whether the patient also has having the deteriorating renal function or not. So thereby, this should be a balance when you are using the guideline-directed therapy in heart failure with reduced ejection fraction. Next slide. Now, use of ACE inhibitor or ARB in such situation has been shown that initially there may be a 50% rise in the serum creatinine level from the baseline. But if this rise progressively goes up and the potassium level goes above 5. In that situation, you have to stop the medicine because there will be then further deterioration of the renal function. So a combined team management is very important while balancing the treatment of heart failure along with the renal failure. Next slide. Now, there is a new need for the newer therapy in managing the heart failure with reduced ejection fraction. Now, beta blockers and RAS inhibitors are well-validated, documented treatment for reduced ejection fraction. And this is underprescribed in patients with CKD or end-stage renal disease. 75% of the dialysis patients with the known heart failure reduced ejection fraction were not on the recommended beta blocker and ACE inhibitor therapy because of the concern about the adverse reaction, such as the hyperkalemia. So novel heart failure management may play a key role in improving the outcome of the CKD patient with the heart failure, provided there is no further deterioration of the renal function. Next slide. Now, what about the ARNI? Now, it is also been shown that when you use ARNI instead of ACE inhibitor or ARP, there is the simultaneous inhibition of RAS activity, also the neprilysin activity is reduced. So you get the benefit of vasodilatation, natriuresis, and diuresis. There is reduction in the blood pressure, and there is less deactivation of the natriuretic peptide, and the RAS activation reduced, resulting in decrease in the vasoconstriction and reduced sodium retention and reduced fluid volume. So they altogether ultimately results in improvement in the heart failure. But remember that this can also cause progressively rise in the serum creatinine and potassium level. So when you treat with these drugs, especially in the advanced stage of the renal failure, you have to take care of the creatinine and the potassium level. Next. So slight increase in the renal dysfunction correlates with the substantial increase in the cardiovascular risk and mortality independent of the standard risk factor. In those patients with a GFR between 45 to 59, the risk is increased by 43%. And when the GFR is below 15 ml, that is end-stage renal disease, there is a significant rise in the cardiovascular disease and the mortality. 43% of the deaths in end-stage renal disease is due to the cardiac disease, and death in the cardiac disease is 10 to 20 times more common in those with the CKD. 50% patient of end-stage renal disease usually suffer from myocardial infarction within the 2 years after initiating the dialysis. Next slide. Go to the next slide. Raghu, can you move to the next slide? Now, Professor Arthur Guyton, as you all know, his name is a famous physiologist. He introduced the crosstalk between the heart and the kidney occurring through the atrial and the renal reflexes, which is very important to control the blood pressure, renal sodium, water excretion, arterial perfusion, and oxygenation of the tissue. So when one organ becomes dysfunctional, the other organ may well be affected as well. Next. Now, when CKD occurs, there is increased volume overload, we all know, and there is also increase in the blood pressure, there is anemia, and CKD is also associated with other non-hemodynamic factors resulting in the myocardial damage. And initially, there is a preserved ejection fraction with the heart failure, but later on, ultimately, the patient develops the heart failure with reduced ejection fraction. So hemodialysis is associated with repetitive hemodynamic instability and the subsequent myocardial ischemia leading to left ventricular systolic dysfunction and heart failure. Arteriovenous graft and the graft-related problem also further aggravate left ventricular dysfunction, probably because of the hyperkinetic circulation. Next. So finally, there is a cardiorenal axis or cardiorenal syndrome develops because of the simultaneous dysfunction of the two organs. Next. And this cardiorenal dysfunction has been divided into the 5 stages. And the stage 1, when there is an abrupt worsening of the cardiac dysfunction leading to acute kidney injury. And stage 2, there is a chronic abnormality in the cardiac function leading to progressive chronic kidney disease. And in the stage 3, there is abrupt worsening of the renal dysfunction because of the acute cardiac disorder like heart failure, arrhythmia, pulmonary edema. And at the stage 4, the chronic kidney disease like chronic glomerulonephritis, and that can also lead to the adverse cardiac function and increased cardiovascular event. And finally, the systemic disease like diabetes, sepsis can also cause simultaneous both cardiac as well as the renal dysfunction. Next slide. The American and the Heart Association and the American College of Cardiac Foundation, they have shown, although there are many landmark clinical guidelines for managing the heart failure as well as the CKD, there are no agreed guidelines for managing the heart failure with the cardiorenal syndrome. So thereby you have to think how to manage this situation. Next slide. Now, the KDO-QI group, they have suggested the level of care of the heart failure offered to the people with CKD should be the same as is offered without the CKD. So thereby the standard guideline directed therapy, if the patient renal function permits, including the SGLT2 therapy, where the GFR remains above 30 ml per minute, can help to reduce the cardiac function, keeping a watch of the whether there is progressive deterioration of the kidney function or not. Next slide, please. So these are the drugs and your ACE inhibitor. Go to the next slide. And we all know that use of ACE inhibitor, if the patient tolerates initially and there is no rise in the serum potassium of the creatinine level above the target range, so then you can continue with the drugs. But if there is a progressive rise in the serum creatinine as well as the potassium level, you have to stop this drug for managing the heart failure. Next slide. So same applies also for the ARB. So the same policy also as it is with the ACE inhibitor, and the drugs are commonly used, the telmisartan, candesartan, and valsartan. Go to the next slide. Beta blockers is often underused, I must say, and this is the very important drug for reducing the remodeling when there is a ejection fraction less than 40%, commonly used bisoprolol, carvedilol, or metoprolol. And it has been shown that even the patient is on dialysis, beta blockers does not show any adverse effects on the renal function unless there is hypotension. Next slide, please. Aldosterone antagonist, again, it is also contraindicated when the serum creatinine is more than 2.5 or when there is a use in the situation where the progressive rise in the potassium and the creatinine level. Next slide. So diuretics is only useful during the volume overload stage. Loop diuretics commonly used intravenous dose. And as soon as the patient is volume depleted, you should stop diuretic because it has not shown any mortality benefit in heart failure with reduced ejection fraction. Next slide. And management of arterial hypertension, as you all know, in the heart failure with the CKD, the important medicine, of course, was the ACE inhibitor or ARB, but provided the renal function is preserved. And beta blocker is also very important drug, and you can use amlodipine for controlling the blood pressure and diuretics in the volume overload stages. But most of the time, this is really a very resistant type of hypertension and is difficult to control. Next slide.
Dr. Banerjee, you have already exceeded by
only 2 slides. So hemoglobin or anemia should be corrected by IV iron therapy or EPO, apostat. So that can be corrected, and also to minimize the vascular calcification, and hemodialysis ultrafiltration required when there is the CKD 5 stage, and ultrafiltration is particularly important in refractory heart failure, which is very useful. Next slide. So inotropic therapy is only showing the symptomatic benefit without any mortality benefit. Next slide. And diet, the 1500 to 200 kilocalorie, fluid restriction 100 to 1500 ml, protein up to 0.5 gram per kg, salt restriction 5 to 8 gram, fat restriction 20 to 25 gram, and low phosphorus, potassium, and adequate vitamin. Next slides. So finally, the patient with deteriorating renal function have serious concern as regards the efficacy, safety, and cost effectiveness of the heart failure therapy to reduce ejection fraction. RAS inhibitor like ARB or ACE inhibitor can cause temporary renal dysfunction. Current clinical studies and evidence-based medicine have contributed significantly to our understanding of treating the strategies of heart failure combined with CKD. As new data emerges, we have to update our clinical practice and treatment guidelines, which may involve modifying the old paradigm and prescription and embracing the new one. Thank you for your kind attention.
Thank you, Dr. P.S. Banerjee. Actually, Dr. P.S. Banerjee needs no introduction. He is the president-elect of Cardiological Society of India National, and also the scientific committee chairman. I thought that he will be starting as the moderator, but as per the list, his name was not there. That's why I asked like that. But having said that, I think the experts can give 1 or 2 comments because of the time constraint, we'll have to go to the next topic very soon.
Dr. Das, you have Chairman Dr. Khan along with you.
Okay, Dr. Khan, could you give 1 or 2 comments?
Sir, what about the role of SGLT2 in case of early CKD and heart failure?
Yes, that I already discussed that this is now an evidence-based drug to treat the patient with heart failure, reduced ejection fraction. In the CKD up to stage 3 and maximum GFR say up to 30 ml per minute. But when it reduced to the stage 4 or stage 5, you should be very careful for using all these guideline directed therapy, particularly the ARB, ACE inhibitor as SGLT2 inhibitor or mineral receptor antagonist. But there is no restriction of controlling the beta blockers in such a situation.
Sir, we have in our expert panel Dr. Prahlad Chakraborty from Toronto. He has SGLT2. He is working in basic science in SGLT2 and he has published papers in Cell. I think he is there. He can tell about SGLT2 and heart failure and the reduction of ventricular arrhythmia. Dr. Prahlad?
Thank you, Sunandan. Can you hear me?
Yes, we can hear you.
Yeah, thank you very much for inviting me. So, yeah, SGLT2 inhibitor, it's actually, I work on arrhythmia. My main area of interest is ventricular arrhythmia and translational medicine. So we have done some studies on guinea pig model, and we found some very good things. So as Sunandan currently nicely pointed out, that SGLT2 inhibitor is the only drug which has been found to reduce the progression to the cardiorenal syndrome, as well as it can prevent cardiorenal syndrome and it can reverse cardiorenal syndrome. All the other drugs, because they alters the hemodynamics, it's not. So we have studied one thing. We have found that actually SGLT2 inhibitor is one drug that acutely increases the cardiac contractility. By acutely increasing the cardiac contractility, actually it increases the renal blood flow and decreases the cardiorenal syndrome. But if we looked at the previous data, all the drugs that increases the cardiac contractility, those are associated with increased arrhythmic death. So they don't have any effect on the mortality, or they increases the arrhythmic death, including digoxin. So this is the only drug actually. We did a study that it reduces the ventricular arrhythmia reductions, and how it causes it. Actually, it's a very complex effect. It's a mitochondrial metabolic modulator through which it can alter. It can change the calcium dynamics. And after our data was published, actually there was a meta-analysis published in Heart Rhythm, which demonstrated that actually SGLT2 inhibitor also reduces the sudden cardiac death in patients with heart failure and reduced ejection fraction. So I think it's a very promising drug in heart failure, and this is the only drug, in fact, that can be given even with compromised hemodynamics. That's a very classical feature of the myopathic myocardium. Yeah, thank you.
No, Dr. Chakraborty, be specific that whether it can be given with the GFR lower than 30 ml or not.
No, this is a
for year or not.
This is a pharmacokinetic. So all the drugs, when they first come, they are always
we do not have that recommendation as of now. As of now, we
that's
do not have.
I'm telling. That's I'm telling that when all the drugs connected, all the drugs are initially not recommended in any GFR below 30.
Now I would like to ask Dr. Banerjee one specific question, that whether those patients on hemodialysis, any group of drug can be used.
That is what I have already told, that the only drug that can be used when the patient is on hemodialysis is the beta blocker. And the beta blocker is often underused. Only you have
many times during hemodialysis, those patients who are on chronic hemodialysis, whether sacubitril valsartan can be used, or it can be used in adequate dosage. If you
if the patient is in the end stage renal disease, where the GFR is less than 20 ml, so I don't the telmisartan or any
end stage.
Yes, patient is on hemodialysis, and the next day you will find that whether the potassium or creatinine, because of the chronic use of ARB,
that you can control by hemodialysis, adequate hemodialysis and ultrafiltration.
There is no documentation, though no guideline with the use of ARB on the patient with chronic hemodialysis, but only the recommendation is that to control the blood pressure, you can use the maximum tolerable dose of the beta blocker, which will also help to reduce the arrhythmogenic cardiac death. Because this is a drug like particularly bisoprolol or metoprolol, they have got good anti-arrhythmic effect.
Mm-hmm. But our nephrologist friend many times say that those patients with chronic hemodialysis, we can control potassium level as well as ultrafiltration. There you can use a reduced dosage of this sacubitril valsartan.
That may be their observation, but there is no guideline.
Quick comment.
We do not have any recommendation as of now.
Yes. Correct.
Spandan?
Actually,
muted.
in continuation of Dr. Amol Khan's view, most of nephrology colleagues and friends tend to overuse these rash blockers in established ESRD who are under good maintenance hemodialysis program with frequent monitoring, and we cardiologists tend to underuse these rash blockers with the fear of
We are
less
afraid of
monitoring
using
and irregular follow-up of patients. So yes. So I agree with the view of Dr. Amol Khan as he expressed. Thank you.
Yeah, thank you, Dr. Banerjee, and all the panelists for giving good inputs regarding this very, very important facets. And is Dr. Naveen Bhamri present?
Sir, it will be given by Dr. Rotin Karmakar.
Then Dr. Rotin Karmakar, you start your deliberation, please.
Oh, okay. Thank you, sir. Am I audible?
Yes, you are.
audible.
Okay. Just for a second. Is my screen visible?
Yes.
Okay. Thank you. At the outset, I would like to thank the organizers for inviting me for this topic in this academic session. This particular topic appears to reflect the recently presented study in the last month, ACEI. Several years, pharmacotherapy for heart failure is linked to improved mortality and morbidity, included ACE inhibitors, ARB, beta blockers, and MRAs. It's not moving.
Routine slides not moving.
Kindly click on that slide and move, sir. Just click on it. Yeah.
Okay.
Yeah.
In the recent years, after the landmark publication of paradigm heart failure, the ARNI has been recommended as a replacement for ACE inhibitors in patients with heart failure with reduced resistance fraction. However, the superiority of ARNI in different subsets of heart failure is yet to be established. In the paradigm heart failure study, which included more than 4,000 patients with less than 40% ejection fraction, it showed a significantly lower number of CV events or hospitalization in patients who were receiving sacubitril valsartan versus those who were receiving enalapril. In the year 2008, another publication came with the Pioneer Heart Failure Study, which included patients who were hospitalized with acute decompensated heart failure, and it showed sacubitril valsartan reduced NT-proBNP more than enalapril. Although not powered for clinical endpoints, a reduction in the rehospitalization for heart failure was noted in this study. This background, this recently presented Paradise MI trial was planned with a goal to assess the efficacy and safety of two molecules in a contemporary acute myocardial infarction population. One being the sacubitril valsartan molecule, which has proven its efficacy in patients with heart failure, and ramipril, which has a large evidence base in post-MI setting. Patients with recent myocardial infarction with ejection fraction being less than 40% with or without pulmonary congestion were randomized to either sacubitril valsartan combination with a dose of 200 milligram twice daily or ramipril 5 milligram twice daily. There was no run-in. These patients were followed up for a median period of 23 months, and it was a vast, it's a large study in which about 41 countries participated, including India. The baseline characteristics of the group, two group of population were quite matching. To highlight is the prior history of heart failure were excluded from these studies, and most of the patients in this whole study were having STEMI as a manifestation of ACS, and most of the people were who were undergone primary PCI. and baseline the most of the people and equally in the two groups, people were getting guideline directed optimal medical therapy. The endpoint, the primary outcome of this Paradise MI study, which included the CV death, first heart failure hospitalization or outpatient heart failure event, showed a numerically lower value in patients who were having sacubitril/valsartan combination when compared to Ramipril, but it didn't reach the mark of statistical significance. As per the adverse events were concerned, both the molecules were equally safe. Only there was some slight more incidence of hypotension in the sacubitril/valsartan group, and slightly more incidence of cough in Ramipril group. So the message from this study came: the sacubitril/valsartan did not result in significantly lower rate of CV event, CV death, heart failure, hospitalization, or outpatient heart failure requiring treatment. And the safety and tolerability of this sacubitril/valsartan in MI setting was comparable with that of ACE inhibitors. After the publication of Paradigm Heart Failure, there are several critical analyses were published in the literature, of which I would like to just point out two in this perspective. One is there was valsartan was given to the maximum tolerated dose while combining with neprilysin, while enalapril was given a moderate dose only. While it could be uptitrated to 40 milligram per day. And second one is a class effect, which was also mentioned, that all the molecules, all the agents of a particular group of drug may not be effective in a particular situation. Like there are some publications in this regard. One being this study, the comparative efficacy of ACE inhibitors in treatment of chronic heart failure in women, which showed that Ramipril therapy in congestive heart failure in women has higher clinical efficiency and better tolerability in comparison to enalapril therapy. In another meta-analysis, which compared the efficacy of different ACE inhibitors, and it was concluded that Ramipril was associated with the lowest incidence of all-cause mortality. So to conclude, ACE inhibitors has been a fundamental constituent of heart failure management for many years, following the landmark studies of consensus and SALT, where enalapril was shown to produce significantly lower all-cause and cardiovascular mortality. And with the publication of Paradigm Heart Failure, it has placed ARNI as the preferred angiotensin antagonist in the treatment of heart failure with reduced ejection fraction. However, the superiority of ARNI over ACE inhibitor in different subsets of heart failure is yet to be established. Efficacy may differ in various clinical settings among agents in the ACE inhibitor group. And lastly, keeping faith over ACE inhibitors may be beneficial in managing patients in economically weaker countries like ours. Thank you for your hearing.
Dr. Das.
Yes, it's a fantastic presentation by Dr. Karmakar. Actually, he has actually opened out a sort of Pandora's box regarding the whole concept of ARNI versus ACEI or ARB or like that. But having said that, most of the guidelines have put now ARNI at the topmost level. And as you know, the recent ACC guideline also highlighted about the quadruple therapy and as the sheet anchor for heart failure management. And there, ARNI is the #1 drug because of the tremendous beneficial effect of the ARNI as compared to the ACE inhibitors, both in the acute phase and in the ongoing hospitalization phase. And not only that, in terms of reducing mortality and morbidity, as well as reducing the rehospitalization, which is a very, very important marker for increased mortality. So he has definitely shown his guts to say that ACE inhibitors might be of benefit. We are surely agreeing with him, but definitely ARNI is now the drug of choice. Any other comment, a single comment will be very encouraging.
I would like to make a comment, Dr. Das, over here.
Yes, please.
That what Rothin said, that superiority of sacubitril valsartan over ACEI is not established, and it cannot be. I don't agree with this viewpoint, because what he tried to mention, that enalapril and ramipril are not the same molecule, and many times ramipril may be more effective. But from the earlier studies of ACE inhibitors, as early as 1992-3, that is consensus solved, they are all studied on enalapril. And later on, ramipril came into the forefront, and we have a lot of discussion about HOPE and HOPE sub-studies. But there was nowhere it has been mentioned that ramipril is a better molecule than enalapril. That's why I differ with this viewpoint. We cannot take home message that ACEI may be better or at least equivalent to sacubitril valsartan. Rothin, would you like to?
Oh, yes, sir. Yes, sir. Yeah, I completely agree with you, sir. In all with all the respect, but I just it's a medical debate session, so that's why I wanted to promote my issue by just
then it's fine. Let us hear from Pandey.
Yeah, please.
Good evening, friends. Only limited point regarding Rothin is that this is not really congestive heart failure. You excluded the pre-existing heart failure and you started the RAS block at 4 days after an event with asymptomatic or slightly symptomatic heart failure. I think this is a different ball game, and there also ARNI was non-inferior. So let me begin my case. I have been asked to speak on heart failure management with preserved EF. Do we see some hope? Really, we have got hope not only on a diagnostics part. We now better understand how to diagnose heart failure preserved EF, but on a therapeutic part, I think it's an abysmal performance, because apart from the diuretics and probably some ARNIs, some spironolactone, nothing really works. But it is important that we understand in our day-to-day clinical practice that heart failure preserved. Western data says around half of the heart failure are preserved. Indian data is around 1/3 of the cases, because probably we are missing many. And definition is varying across the continent. I'll discuss those things. But it is also important, when we were doing our post-graduation, we were taught heart failure preserved EF is probably a misnomer. Quarter of patients are not actually heart failure. Probably they are suffering from anemia, COPD, and so on and so forth. But I think that has been refuted nowadays. It's not a misnomer. But we must try to explain other causes of dyspnea rather than just EF, which is very easy. You have a shortness of breath and you do echo. EF is more than 50%, some rise in BNP. You tend to think that this is heart failure preserved EF, but unfortunately, this is not the scenario. I'll present you 3 cases here. And we know the ESC guideline has told us that with signs and symptoms of heart failure with EF more than 50%, and you have BNP rise, if all 3 are there, you need to have at least one more parameter, either structural or functional abnormality. Recent 2021 ACEI has published a universal definition of heart failure, where heart failure preserved EF has stood the ground of that EF has to be more than 50. Mid-range has been nowadays diagnosed as mildly reduced, and whereas there's another entity known as improved EF. So we should also be mindful that when we do a BNP, because NT-proBNP has to be elevated to diagnose heart failure preserved EF, there will be certain patients where BNP will not be that high, particularly the obese patients, and if they have got a prior treatment, particularly with the diuretics, and in diabetics, if they have got SGLT2 inhibitors on board before the heart failure really sets in. So we have to mindful. Let me show you 3 cases and we'll see how difficult it is to diagnose if you don't follow the paradigms of diagnosis of heart failure preserved EF. Now, this lady who is obese, BMI of 34, she is on 2 anti. Also gives history of atrial fibrillation, and on echo, EF was more than 50, but E prime was 16, and NT-proBNP is 280. So we have got ESC criteria met here, at least gives you the probability that this is a case of a heart failure preserved EF. But if you do this Mayo score of S2F scoring, and here you will find that score is really high. In this patient, it is around 6. So it meets the criteria. So anything where this score is more than 5, it almost confirms the diagnosis of heart failure. Whereas if it is somewhere between 2 to 4, it is into the gray zone we need to work on further. Whereas the second case, who is a 59-year-old gentleman with hypertension on single drug, well controlled, complaints of dyspnea, he also gives history of COPD with borderline PS systolic pressure of around 27, and EE prime ratio is only 7, and NT-proBNP is normal. Now, naturally, you will not diagnose this as a heart failure unless probably his BMI was pretty high, where you'll get lower NT-proBNP. And if you look at this ESC criteria of looking at a heart failure association preserved EF, here score is really 0, and probably this dyspnea is not related to a heart failure. And the third case, obese lady who has got unexplained dyspnea with history of drugs for hypertension. She is pre-diabetics, no AF, no history of CAD, physical exam is normal. Look at her echo. EE prime ratio is 11, it's not more than 15, it's on the borderline zone. E septal velocity is less than 7, but left atrial volume index is moderately increased, it's not more than 34, whereas the pH is documented on echo, and NT-proBNP is on the lower side. So you are really in a fix. She's symptomatic, she's dyspneic with normal BNP, but echo tells you that she has got a diastolic dysfunction. What do? Do you diagnose it as a heart failure? Look at the score. A score is around 3. So it is into the intermediate dose level. So in these patients, we really need to do some sort of stress testing so that we confirm. So stress testing can be done in an echo lab with some exercises we can do in a cardiac catheterization laboratory, but it is important to exclude coronary artery disease in majority of the patients of heart failure because that's a treatable condition. And by doing angiogram, we get chance to measure the LV and diastolic pressure and PA pressure, which is more reflective than what we get on echo in obese ladies. So some form of assessment is needed in those with a borderline cases. So it's basically mixed bag, but diagnostic part, we have got some hope. On the therapeutic front, this is a busy slide that shows that we really do not have a treatment for heart failure preserved EF apart from use of diuretic, make him asymptomatic, decongest him. FDA has given clearance for ARNI based on Paragon heart failure, but let me remind you, inclusion criteria in this Paragon was EF more than 45, and FDA said you can use in a fairer gender as well as in those with EF less than 57%. But basically, Paragon heart failure was a negative trial if you look at the primary endpoint. And some post hoc analysis in TopCat also shows probably spironolactone has got some value. We are still waiting for SGLT2 role in heart failure preserved EF, We have got soloist published. Sotagliflozin has been shown to be of help in preserved EF. Dr. Soumik Goswami, after our session, will have a good discussion on SGLT2 inhibitor in cases of heart failure. But other things are investigational, like role of nitric monoxide cyclic ZMP PKZ axis, whether you do a CRT or you do CCM. I think Aparna Jaiswal will discuss those things in heart failure. So there are various fronts where there has been investigational therapies being tested. And it is also important in heart failure preserved EF that you look at the phenotypes, because it's a heterogeneous syndrome. We always try to look out and exclude the TTR amyloidosis, because our hematologist friends will treat it. That's a curable sort of a cause of heart failure preserved EF. So we have a various subsets like aged, elderly, hypertensive patients. We have got obese, diabetic, CKD, obstructive sleep apnea type of patients. We have got pulmonary hypertension, mostly post-capillary type of patients with heart failure. And of course, a good number, around 20-25% will have CAD. And there are a good number of patients with AF where probably ablation will help. So unless you know the phenotypes, it will be really difficult to treat these. And we have got atrial shunts nowadays. Our pediatric, our pediatric cardiologists are using these shunts to reduce the LA pressure, but has never been shown to improve the mortality. So let me stop here so that we can have some discussion. Thank you very much for the patience hearing. Yes, Mrinalda.
Thank you, Dr. B.P. Pandey, for your beautiful exposition of a very, very complicated subject because of the basic thought block in the process of the diagnosis as well as the definition. But however, you have highlighted most of the points, especially in terms of management. Really, there is no other treatment other than diuretics in heart failure with preserved ejection fraction, and ARNI has been only helpful in the female patients that as per the SAP study, and the spironolactone and all these things, the eplerenone, they are also helpful to some extent in reduced reduced compliance because of the hypertrophy factor. If it is diagnosed as hypertrophy causing the ventricular diastolic dysfunction, they can be of some help. But no concrete data are available on the the aldosterone antagonists as yet now, and we'll have to wait for further management. And I think Sunandan is hitting the chat box all the time. We are running short of time. All the speakers have done excellent job, and the participants and the panelists, they have also done fair comments, and I really appreciate every one of you with a big round of applause. Thank you. Over to Sunandan, please.